me that there are a couple of undergraduates also attending the meeting. I thought I will just try and make them understand why we need to classify the tumors. And before I delve into the topic, I'll touch upon some basic concepts which are required for the understanding of my talk, and also my topic, although the male genitourinary system encompasses, and that kidney encompasses the kidney, the prostate, bladder, testis, and the penis, I would be largely basing my presentation on the renal tumor, because that is where the major update has come on. And this I will try and do with a few case illustrations so that people would be able to understand me. And I'll be briefly touching on the other areas. Now, the question first is why we need to classify tumors. The answer would be the definitive diagnosis and the classification of individual cancers are very much required for the clinicians or the treating team to decide on the management strategy, also to decide on the follow-up protocols, and also to prognosticate the disease process. This is also required for the research into the cancer causation and also prevention. And until recently, histopathological criteria formed the basis of any tumor classification. However, there had been advancements in various fields which has enabled us to gather more knowledge regarding the molecular genesis of the various tumors. Thus, today we stand in a state where the traditional methods are insufficient for a categoric diagnosis of any tumor. Moreover, the advancements in the fields like digital pathology and image analysis have also helped us in producing more new insights into the understanding of the tumorogenesis. The advancements in the computer technology, including the artificial intelligence, has also helped us in producing more clinically applicable aids to the diagnosis of tumor. So with that introduction, I would say that the classification of the male genitourinary tumors and the kidney tumors started way back in 1973, and the WHO classification came in blue books, what the pathologists call as the blue books. And the WHO classification as the IARC, or the International Agency for the Research on Cancer, is the agency which is responsible for the upbringing of the WHO fascicles, which will detail the classification, the molecular genesis, and other details of the tumor. So as I said, it started in the 1973 with the first fascicle, the second being in 1999. 2004 is the year which saw the third edition of the WHO, followed by the fourth edition in 2016, and 2020 is the year which came up with the fifth edition of the tumor classification. Now, coming to the classification of renal tumors, if I ask one of the undergraduates, if there are any in the audience, to tell me how do you classify tumor of any site for that matter, I'm sure that they would one would start classifying it as epithelial origin, mesenchymal origin, hematolymphoid, so on and so forth. And in the kidney, the classification, I'm just briefing the epithelial tumor, the classification of the epithelial tumors, and the classification is based on the origin of the tumor. The tumors which takes its origin from the proximal tubule, that is the clear cell conventional carcinoma and the papillary renal cell carcinoma, whereas from the connecting tubule is the chromophobe renal cell carcinoma originating, whereas from the collecting duct, you have a set of you have the tumor that is collecting duct carcinoma, or the Bellini duct carcinoma originating. So this when the WHO started off in 1973, they just had a handful of tumors with the various details available. And if you ask us, the pathologists, the basis on which we try to classify the tumor would be on these parameters. We try to analyze the cytoplasmic features, look whether the cells have any clear cytoplasm or eosinophilic cytoplasm. So in the kidney, the tumors which depict a clear cytoplasm would be a clear cell conventional, which forms the vast majority, 70% or more of the kidney tumors are of the clear cell entity. And the chromophore renal cell carcinoma is yet another type of tumor which also exhibit a cytoplasmic clarity. And the second parameter would be we would be looking at the architectural feature. Any tumor which forms a papillary architecture, the tumor cells arranged in the form of finger-like projections, we call it as a papillary tumor. And there are a subset of tumors which have got resemblance to the embryological structures. And in the kidney, those subset of tumors are the metanephric adenoma. And there are a subset or a long list of tumor in the, especially in the latest WHO, which shows a genetic predisposition. One example being HLRCC, which stands for hereditary leiomyoma associated renal cell carcinoma. I'm not here to fear you by giving you all big names, but I'll just try and explain all these entities by some cases that we have. And I'm sure, being an undergraduate, everybody, each one of us would have seen a similar gross, wherein when the pathology teachers ask us to describe, we would start describing it as a renal tumor with a variegated appearance and so on. And this is the microscopy which depicts the tumor as having abundant clear cytoplasm. Okay, so this is how the conventional clear cell renal cell carcinoma of the kidney look like. Now, I said you have also a subset of tumor wherein the tumor cells are arranged in the form of papillae. In the inset, you can have the tumor cells are forming some structures, which are resembling finger. Okay, so these are the papillary renal cell carcinoma. I am not getting into the finer details. I know the vast majority being a non-pathology crowd, I will not be in a position to encourage you if I go in for the detailing. So, and we also look at the various other features like the cytoplasmic color, the nuclear features, are there any perinuclear haloing, etc. So these are some examples, definitely tumors of the kidney, which comes under different tumor entities. Say, for example, the lower left picture would, if I ask a pathology PG in the crowd, they would definitely say that they would think the third tumor as being a chromophore for obvious reasons, which I'm not going into getting into the details. Now, so is that all about pathology department? Is that we look at the different colors, the cytoplasm, and play with a display of colors and try to name a tumor? No, it is not just that. Actually, the diagnosis of pathology starts from the very moment that we receive the specimen in our hand. And the major part of pathology reporting, I always keep telling my postgraduates, the time spent at the cut-up room or the grossing room is the time that is gained at the microscopy. If you do a thorough grossing, which means that you have to look the tumor. Say, for example, this is the gross description of a nephrectomy specimen wherein we received a kidney with a tumor. So we need to establish the size of the tumor, the extent, whether it is extending, whether it is confined to the kidney, whether it is extending to the perinephric fat. There are many factors or features that as a pathologist, we need to find time to observe certain features which are definitely which are required for the diagnosis of the tumor, like whether the tumor is extending to the renal vein, whether it is extending the renal sinus, etc. So after a thorough gross evaluation, we decide on putting certain bits in the cassette so that we are able to give a meaningful diagnosis out to the surgeon who has sent the specimen, and we also form a major part of the multidisciplinary team, and we also participate in the tumor board discussion wherein the different aspects of the tumor is discussed and a decision is taken. The extent of the tumor, whether there are any bad prognostic parameters. Say, for example, in this particular kidney, it was a clear cell conventional renal cell carcinoma, but it showed an extensive sarcomatoid change. What does that mean? That's a bad prognostic parameter as far as a clear cell renal cell carcinoma is concerned. So whatever be the advancements that has happened, the cornerstone of any diagnosis, tumor diagnosis, is made by the morphological assessment. This sarcomatoid change you can only see if you do a thorough grossing and also a thorough evaluation of the microscopic sections. Why is it important? Why is that a sarcomatoid change is important in the management of the tumor? This is the explanation for that. Any tumor which shows a sarcomatoid change does not respond to the usual treatment, that is sunitinib. You may have to give other molecules so that the patient gets a benefit of it. Here in this example, they have analyzed nivolumab and versus the sunitinib in case of a renal cell carcinoma, which showed a sarcomatoid differentiation. So every other aspect is important at the treatment, at the level of treatment. Now, and each morphology that we see definitely has got a genotypic correlation. Likewise, if it is a clear cell conventional renal cell carcinoma, there is the genotypic correlation is that it will exhibit a loss of the chromosome 3, the short arm of the chromosome 3. Likewise, the papillary renal cell carcinoma would show a gain of chromosome 7 and 17. So that is regarding the genotype-phenotype correlation. And this is the classification of the tumors that can originate from the kidney. It's a big list, right? Starting from the epithelial to the mesenchymal, the neuroendocrine, the hematolymphoid. You can have any tumor that can arise in the kidney, but I will be concentrating on the epithelial tumor, which takes its origin from the renal tubules, the proximal or the distal or the collecting duct. Now, this is the latest WHO update of the 2022 classification. You can see the list it's a big list, and even new entities you can see that there are a few tumors wherein there is it is labeled as new with the red ink there. And these are the tumors which got an entry in the latest classification. And there are a big list of tumors which are even now under the provisional category waiting for its inclusion into the WHO classification. So, and you can also see the right hand side of this slide that there are a set of tumors which are like considered as molecularly defined renal cell carcinoma. What does that mean? For the definitive diagnosis of these tumors, one has to have a molecular assessment. Without a molecular confirmation, you cannot confirm on these set of tumors. Probably with certain morphological features, you can suggest the possibility, but however, for a confirmatory diagnosis, you need to go for a molecular analysis. A genetic level assessment is required. Now, having briefly given an intro for the renal cell tumors, we'll just quickly look at one case. This is about a 40-year-old male who was incidentally detected to have bilateral renal masses. So he was evaluated for the same, and the CCT abdomen, which was done, showed a well-defined lesion, which was about 4 centimeters in maximum dimension, with a which exhibited a mixed density and also cystic areas, and few other lesions also were noted in the lower pole of in the same kidney, which were predominantly cystic and classified as type 1 Bosniak cyst. And at the same time, the other kidney, that's the left side, also showed lesion which was maximum of the size 3 centimeters. And also another lesion which was 6 into 9 millimeter in size at the anterior inferior pole. That means the tumor were involving both the kidneys, and there were multiple in number. And because of the radiological characteristic of the tumor, the radiological possibility that was given was that of an oncocytoma. And As part of the workup for preoperative workup, the patient also had a CT chest, and the CT chest done for the as part of the preoperative evaluation also showed multiple thin-walled cysts in both the lobes of the lung, predominantly involving the lower lobes. And the patient underwent a radical nephrectomy of the right side and a partial nephrectomy on the left side. And this is what we got to see on the gross. The right-sided kidney showed an encapsulated mass with cystic areas, yellowish in color, and areas of hemorrhage as well. Whereas the left-sided kidney were more solid in appearance and vaguely lobulated. We extensively sampled the sections from both the tumors, and this is what we got to see. Like if I take you back to those slides where I said that tumor was having clear cytoplasm, pink cells, and all that, you would definitely agree to me that this particular tumor has got cells which has clear cytoplasm as well as pink cytoplasm, and some of them, especially the first image, is showing nest or islands of cells wherein the tumor cells were like seen to be floating in some edematous stroma. This is exactly the microscopic image of an oncocytoma, whereas this clear area, my PGs would say that this is kindly suggestive of a chromophobe renal cell carcinoma. So looking at the morphology, we thought we were dealing with a hybrid tumor, means a combination of two or more tumors, and thus we suggested the possibility of a bird-hog-Dubé syndrome because of the hybrid nature of the tumor that we got to see, and advised for the workup for the bird-hog-Dubé syndrome. And the genetic evaluation was done, and which showed the evaluation for the folliculin gene showed a missense mutation involving the exon 4 on chromosome 17. What does that mean? This is the confirmatory diagnosis for a bird-hog-Dubé syndrome. So what is this bird-hog-Dubé syndrome? This is a rare syndrome of inherited renal cell carcinoma also characterized by cutaneous lesions and pulmonary cysts, which can lead on to pneumothorax in vast majority of patients. As you can see, our patient had renal tumor, which were bilateral, multiple in nature, and also had pulmonary cysts. But our patient did not have any cutaneous lesions. And in bird-hog-Dubé syndrome, the kidney tumors can range from benign, that means an oncocytoma, to malignant. The malignant tumor could be a chromophobe renal cell carcinoma or a clear cell renal cell carcinoma. And the risk of bird-hog-Dubé syndrome patients having a kidney cancer is about 7 times than that of the general population. And this syndrome is caused by mutation of the bird-hog-Dubé gene or the folliculin gene, which is located at the 17th chromosome, and the skin lesions being fibrofolliculoma, trichodiscoma, acrocordon, etc., and other lesions being pulmonary cysts and renal tumors. So the European bird-hog-Dubé syndrome consortium has come up with a diagnostic criteria for the same, and this includes the patient if 2 or 3 of the following manifestations are present, like multiple bilateral lung cyst with basal predominance, and a first degree relative with the bird-hog-Dubé syndrome, or onset of renal tumors in less than 50 years, as we saw in our case, which is multiple and bilateral. And the renal tumors could be chromophobe, oncocytoma, or a hybrid tumor. So our case was very much fitting for a bird-hog-Dubé syndrome and was confirmed by the genetic analysis. Now, yet one more case for detailing of yet another scenario. This is about a 17-year-old girl, again, who was incidentally detected to have a renal mass. She was evaluated in an outside hospital, and the MRI done there showed a well-defined, sharply and smoothly marginated, rounded, multiloculated, complex cystic lesion, which was maximum size of 4 centimeters. And with this MRI, she was referred to us uro-oncology department. And the CT done in our institute also confirmed that there was a lesion very much in the kidney, which showed cystic area and also areas of calcification and heterogeneous enhancement also. And since it was a small renal mass, any renal mass which is less than 4 centimeter qualifies to be called as a small renal mass. Since it was a small renal mass, the child was subjected for a partial nephrectomy. And this is the gross that we got in the department. As you can see, this is as explained in the radiology. This is again a tumor which is having both cystic and solid areas. The microscopy sections were taken, and this is the microscopy again depicting the gross. These are the cystic areas. In between, you're seeing some solid areas. This is the closer view from the solid area, and this is again cystic and solid. The cystic area here, the solid area is formed of tubules of varying sizes, and these tubules are lined by cuboidal cells with eosinophilic cytoplasm and very fine chromatin nuclei, which were having fine chromatin. We were not in a position to identify any mitosis or any alarming feature in the tumor that in the sections that we studied. So correlating the gross and the microscopy with the tubules and the cyst, we gave a diagnosis of tubulocystic carcinoma, which is a new entity which got its place in the 2016 update of the WHO classification and is considered as a very indolent tumor with a very good prognosis. So did the story end there? Definitely not. If that was the situation, I wouldn't have presented it here. My clinician was not I wouldn't say that he wasn't satisfied with the diagnosis, because it was showing both tubular and cystic area. But considering the age of the child was only 17 years. The clinician decided to send the sample of the child. The blood sample was sent for a germline evaluation. And this is what we got. About 25 genes, as recommended by the American College of Medical Genetics and Genomics, were evaluated to rule out a hereditary predisposed renal tumor. And this is what we got. There was a germline mutation seen in the FH gene. FH stands for fumarate hydratase, and the diagnosis, and they had pointed it out that as particular change as likely pathogenic, thus bringing us to a diagnosis of FH mutant or a fumarate hydratase mutant renal cell carcinoma, which is also known as hereditary leiomyomatosis and renal cell carcinoma. Again, a hereditary tumor. And this is a newly recognized entity in 2016 WHO, but there had been some changes after it was described in 2016. And here, this is defined. This is a tumor which is defined by a germline mutation in the FH gene. And this particular gene is situated in the long arm of the chromosome number 1. So what happens is, as you all know, if you all can brush up your biochemistry knowledge, you know that fumarate hydratase is the enzyme which has a crucial role in your Krebs cycle, which helps in the conversion of fumarate to malate. So when this enzyme, due to the mutation of this gene, the enzyme is not functioning properly, so the conversion of fumarate to malate does not happen. So there is an accumulation of succinate happening within the cell. So this and the oncogenesis in this particular situation is driven by this particular metabolic derangements that is happening because of the defective fumarate hydratase enzyme. And HLRCC patient, or the hereditary leiomyoma and renal cell carcinoma patients, also show high frequency of cutaneous and uterine leiomyomas. If you see a young patient, a young girl who is having uterine leiomyoma or cutaneous leiomyoma, you have to extensively work up that child, get an abdominal scan also, and rule out that there is rule out whether there is a renal cell tumor also. And I've already said that here the defect is in the deficiency or defective functioning fumarate hydratase enzyme. So you have an IHC marker which is available for the fumarate hydratase, and thus it helps us to confirm whether the tumor is due to an FH deficiency or not. But definitely genetic testing is considered as the criteria for the diagnosis of the HLRCC-RCC. So I said this particular tumor was described as a new entity in the 4th edition of WHO, that is 2016. But when it was described as a very aggressive tumor, which would show the cells arranged in the form of papillae with very prominent nucleoli, eosinophilic cherry red nucleoli, with very frequent mitosis, necrosis, and all alarming features. This is the initial description for a HLRCC-RCC. So if you compare this particular image with the image that I showed you as the tumor that we saw in that 17-year-old girl, this was definitely not fitting in for an FH deficient or an HLRCC. But after the description in 2016, there had been many papers which has come up, which has described that this particular tumor can also have other morphology like the tubular and the tubular cystic pattern that we got to see in our case. But one encouraging news is that any tumor which shows a tubulocystic pattern and the low-grade nuclear morphology that we got to see in our case occur mainly in young women, as is seen in our case, and all shows a relatively good prognosis in comparison to those tumors which shows an aggressive morphology. And regarding the follow-up of our child, the child is 3 years post-op now. Initially, she was on 6-monthly follow-up, and the last follow-up was in the month of February 2022. The radiology done did not show any change in the kidney or in the uterus, and she has no cutaneous leiomyoma. Not only she, none of her family members also have any of the features described for an HLRCC syndrome. So that is the conclusion of that case. So it's not just bird hog Dubé or the HLRCC that shows the syndromic association. Our very much conventional, the most common one, the clear cell conventional renal cell carcinoma also also shows a syndromic association. That is, it is seen in individuals who have von Hippel-Lindau syndrome. And these are the other set of tumors, like you have a set of renal cell tumor which can arise in tuberous sclerosis patient in the background of succinate dehydrate deficiency, wherein you also have renal tumors, paraganglioma, just in the gastrointestinal tract. So there are many syndromic associations wherein renal tumor is one of the part of the syndrome. Likewise, in a SMARC B1 deficient renal medullary carcinoma, ALK rearranged tumor, the list is very long. Why should we know all these entities? Nobody tell you to, by heart all these entities, but you should have a basic understanding of that there are a set of tumors which can show syndromic association and familial predisposition, because if you get to see any such case as an index case in a family, you as a treating clinician is supposed to rule out other association of that particular syndrome and also evaluate the family members to rule out whether any one of them has got the same thing. So that is the take-home message from these two cases. And when do you evaluate a patient for a syndromic or a genetically predisposed renal cell tumor? These are the situations. Whenever you see a renal cell carcinoma developing in a young age, or in a family, in the background of a family history, whenever there are multiple tumors, which is bilateral and multiple on both sides, these are the situations which would warrant a workup for a syndromic or a genetically associated renal cell tumors. So with that, this is in nutshell about the update that has come in the kidney tumors in the 2022 WHO. Little bit on the updates on the prostate. if I ask you what is the most common type of tumor that one get to see in the prostate, as you all know, in men, it ranks second in the list. It's the second most common tumor in the males, and the fifth most common tumor as far as the death, cancer-related death is concerned. And the most common tumor in the prostate is a adenocarcinoma. Adenocarcinomas are tumors which takes its origin from the glandular epithelium. It could be from the acini or the prostatic duct. So the most common type of tumor in the prostate is a prostatic adenocarcinoma. Okay, but you have some rare type of tumors like squamous, adenosquamous and all. And this is one important tumor. The treatment-related neuroendocrine tumor is one tumor which one has to have an understanding about. I'll be detailing about it in a short while. So no undergraduate or no postgraduate, for that matter, no doctor would escape their undergraduate curriculum without even hearing this word: Gleason's grading and Gleason scoring in a prostate cancer. So who is this Gleason? Professor Gleason, Donald Gleason, was a pathologist in late 1960s. That is, he has formulated this grading and scoring in a prostate cancer. And this is the image that he has drawn by himself using pencil and paper, and he has depicted this for the grading of prostate cancer. So the grading is, you look at the pattern, it's again formed of glands, and scoring is like you look at the predominant pattern and the secondary pattern, and then you score, and then you add up the grade and give a final score, Gleason score. The pathology report might say prostatic acinar adenocarcinoma, Gleason score of 4 plus 3 equals 7. So 4 is the predominant pattern there, and 3 is the secondary pattern. Okay, so I'm not getting into the details because for a non-pathology crowd being the majority out there, it will be really boring for you. And I won't be able to do justice if I get into the nuisance of Gleason scoring and grading. But I would say that this particular scoring system has stood the test of time, and even today it is considered as one of the most important prognostic parameter for the carcinoma prostate. But definitely this particular system has gone several revisions after its inception in 1967. The major being in 2014 after a conference in the US, and they have come up with major changes in the 2016 WHO, that is the fourth edition of the WHO. So what were those changes? I said the scoring is by adding the predominant and the secondary predominant pattern. Okay, and if it is and in 2014, that is in 2016, the last WHO came up with a group grading, which is also known as prognostic group grading, which divides the tumor into, which groups the prostate cancer into group 1 to 5. 1 is the basic group that one can assign, and any Gleason score of 6 or less is a group grade of 1, whereas any Gleason score of 9 to 10, it comes under the prognostic group grade of 5. And this is the risk group based on the pathology report, that is the group grade and the Gleason score. One can stratify the patient into various risk groups, the low or the very low risk group being any Gleason score of 6 or less than 6, whereas intermediate is any Gleason score of 7. It could be 3 plus 4, 7 or 4 plus 3, 7, which is not the same. When the pattern 4 predominates, it is a bad tumor. So it will be an unfavorable intermediate risk group, whereas high or very high risk group are any group grade of 4 and 5 comes under the high and very high risk group. So this was the change that happened in the previous edition of the WHO. So what did the latest one come up with then? There isn't much change actually that has happened in the 5th edition, but definitely certain treatment related things are being highlighted in the latest WHO. This is the one which I was telling you all about, that is the treatment related neuroendocrine carcinoma. This is considered as a bad tumor. it shows a lot of, it doesn't follow the usual rule of the usual type of the prostatic adenocarcinoma, in the sense one wouldn't see a very much high elevation of a PSA here when it is a when there is a neuroendocrine differentiation. That is point number one. Point number two, if it is a tumor with a neuroendocrine differentiation, it would show early metastasis and also metastasis to unusual sites like visceral metastasis, which is never heard for an acinar adenocarcinoma, is usually seen in a tumor whenever there is a neuroendocrine differentiation. So what is this treatment-related neuroendocrine carcinoma? This has emerged because of the increased use of higher potency anti-androgen like abiraterone or enzalutamide. And whenever a pathologist comes up with a neuroendocrine morphological suspicion of a neuroendocrine differentiation, it warrants the usage of, the workup with the IHC for a neuroendocrine marker, that is synaptophysin, so that we confirm whether the neuroendocrine differentiation is there or not, which is important for the treatment decision. Now, I said adenocarcinoma is the most common type of tumor in the prostate. It could be taking its origin from the acinine or from the main prostatic ducts. Those which take from the origin from the prostatic duct are called the prostatic ductal adenocarcinoma. In comparison to the acinar adenocarcinoma, the ductal adenocarcinoma forms a small minority, but this and also shows other molecular alteration in addition to the one which is shown by the acinar adenocarcinoma, like alteration in the WNT signaling pathway, like the APC mutation, as one get to see in an adenocarcinoma of the colon. And also there is increased alteration in the DNA. Hello, somebody is talking in between.
Rajesh, please mute.
Okay, so ductal adenocarcinoma, why is it important to know is that there are certain genetic or the molecular changes that is more commonly seen in a ductal adenocarcinoma. So what is that? If you see a ductal component in the tumor that has come across to you, that warrants a germline testing for the germline alteration in the DNA repair gene. That is your BRCA associated gene, which is seen in the breast carcinoma and the ovarian carcinoma in the ladies. The same alteration you can get to see in a ductal adenocarcinoma, and also tumors which show a pattern which is shown on the right hand side. This pattern, my girls would say that this is a cribriform pattern. What is cribriform? Just imagine the cribriform plate of the ethmoid bone. Why is it called cribriform plate? Because you have lot of holes in it, which will help in the passage of nerves from the brain to the rest of the part. So that is cribriform, means lot of holes. Here again, you're seeing a fused glandular pattern, but definitely with lot of holes. When a tumor shows a cribriform pattern, again, it warrants a germline analysis for the BRCA, and also mismatch repair gene evaluation is warranted. So this is an update which is brought up in the 2022 WHO classification. And the NCCN guideline, the National Cancer Comprehensive Network guideline for the prostate, they have come up with a guideline for the germline testing in prostate cancer. So the germline testing includes testing for the mutations in the DNA repair gene, that is BRCA1 and BRCA2, which is required, which is a necessity in the era of precision oncology. And the NCCN guideline recommends the testing to be done in the that is the high risk group that I have already told, and also in those tumor pathology wherein there is a ductal component and also a cribriform pattern. This is the update that has come up in the 2022 WHO. And also in those individuals where there is a family history of prostate cancer, and the cancer has come in individuals less than 60 years, the immediate relatives have died of a carcinoma prostate, or more than 3 cancers running in the family, that is cancer in the breast, in the sister, or in the ovary, in the sister or mother, or some Lynch syndrome associated tumors, or tumors in the pancreas. All these warrants testing for the germline testing in case of prostate cancer. So why is it important? Suppose one documents that there is an alteration or a mutation in this BRCA1 or BRCA2. There is a treatment modality which is available here. These subset of tumors which shows a alteration in the BRCA1 and 2 is shown to show increased response to PARP inhibitors, which are very much available in the market today. And also, if a tumor is associated with the Lynch syndrome, that is, there is a defect in the DNA mismatch repair gene, such tumors are show a response to immune checkpoint inhibitors like I forget the name of the drug. Sorry for that. So that's all about the prostate cancer update in the 2022 WHO. Quickly going through the bladder, I will not touch upon the intricacies of the basic histology or anything for the want of time, but the 2022 WHO has come up with a molecular classification of the bladder cancer. The classification till the 2016 was purely based on the morphology and morphology alone, whereas 2022 has come up with a molecular classification which is very much available for organs like breast, and where the tumor is being classified into luminal and basal. Why should one break their head to stratify the tumor into luminal or basal? Because these tumors, if it is a luminal tumor, it is a tumor which comes under a good prognostic category, whereas basal is a bad tumor. So there are, if you ask me whether one has to have all molecular ours, especially ours being a resource limited country, one would be tempted to ask me whether one should have all these in our armamentarium so that we are able to diagnose it. Definitely the answer is no, because we have some IHC markers available today which can act as surrogates so that we are able to categorize this tumor and do a molecular classification into basal and luminal. And also the 2022 update has come up with a concordance about the PD-L1. PD-L1 is programmed cell death, wherein if you can demonstrate whether the tumor is showing a positivity, there are certain scoring system which at this in this particular audience, I don't think I should be going into the details of the assessment of the PD-L1 status, but you should know that the PD-L1 status is analyzed to take a decision whether the patient would respond to the latest the new kid in the block, that is the immunotherapy. So that is the importance of assessment of the PD-L1 status of a tumor, and the 2022 WHO has come up with the analytics for the same. So that is the update about the bladder. And about the testis, there is pretty much not much change if you come. But 2016, that is the fourth edition of WHO, definitely saw a sea change regarding the testicular classification of the testicular tumors. But the 2022, there is not much change with respect to the 2016, that is the fourth edition. Accepting certain terminology change, and a few of the tumor which was put as provisional entity got a real place in the 2022 WHO. That's all about the testicular tumor update. And now coming to the carcinoma penis, which is, I'm coming almost to the tail end of my presentation. Carcinoma penis, till the 2016 WHO, the diagnosis was purely based on the morphology. And you all know, in the penis, the most common tumor I would say 98% or 99% it's a squamous cell carcinoma and only squamous cell carcinoma. And it's only in the 4th edition that the association of HPV, the human papilloma virus, was also taken into the consideration for the classification of the tumors of the penis, the squamous cell carcinomas of the penis. So now the 2022 WHO also reinforces that the HPV status of the squamous cell carcinoma of the penis has to be demonstrated. The tumor, you should never be satisfied with a report which says that it's a squamous cell carcinoma or it's a verrucous carcinoma or it's a basaloid variant of squamous cell carcinoma. No, definitely no. As a clinician, you have every other right to ask for the HPV status. So how do we get to know the HPV status? You have a surrogate marker again, the P16, which can be done as an IHC, the immunohistochemistry, which would say whether the tumor, definitely the morphology also helps in a greater extent. The usual one, the vast majority being the usual type, which doesn't show an HPV association, whereas the basaloid and the warty basaloid are the tumors which can show HPV association, and the tumors which shows an HPV association are considered to be very bad tumors. So this is the update as far as the carcinoma penis is concerned. Now, that's all about the WHO update about the male genital, genitourinary and the kidney tumors. Now it's time to summarize. Can I ask one of the pathology PGs to summarize whatever you heard? Is Anjali there? Hello. Hello.
Pathology PGs?
Yes, ma'am.
Okay. Anjali, start off. Try to summarize whatever you understood from my talk.
Ma'am, so according to the WHO classification, ma'am, the starting from male genital system, ma'am, so you have covered about the epithelial neoplasms, which includes the papillary, the clear cell, that is, and all the new updates regarding the papillary neoplasms, the Birt-Hogg replicate case, which we had discussed about Birt-Hogg-Dubé, which carries a significant role because it's important to identify the genetic predisposition in case of Birt-Hogg-Dubé. And then, ma'am, the updates on the Gleason's, how was it started? Why is it important about the Gleason scoring system, which we normally use to report in case of prostatic carcinomas, and about the
parameters which would tell us that that particular patient would require a germline analysis, like the age of the patient, a prostate tumor which occurs in a young age, the background of a family history, a tumor which shows a ductal morphology, a cribriform architecture. All these warrants a germline evaluation for the BRCA and the mismatch repair gene. Why is it important? Because it has got treatment implication. Okay, yeah.
And about the fumarate hydratase and the role, the tubulocystic, which was initially diagnosed as a tubulocystic disease, but later on, with the help of the genetic.
You have gone back to kidney, huh? Okay.
So some cases which we discussed.
Okay, yeah.
Interesting cases.
SLRCC. Again, in the kidney, it's important because one has to, one should be in a position to pick up syndromic or genetical tumors which has got a genetic predisposition. Again, there are set criteria wherein you have to analyze, subject a patient for the further workup for either to rule out or confirm a genetically predisposed renal cell tumor, right?
Yes, ma'am.
Okay, and in the testis, we didn't see much of any update, excepting a few change in the terminology, which I would definitely highlight it for the pathology crowd when I take a class separate, because it's not going to like please the other crowd, which forms a major chunk here. And in the penis, definitely there is the take home in a carcinoma penis is that any pathology report should carry the HPV status of that particular tumor. That's very, very important. And in the bladder, the 2022 came up with a molecular classification, as is already there in the breast. You have the molecular classification into basal and the luminal. Luminal being better, basal being bad. Okay. Okay. So that is all about the in nutshell about the 2022 WHO. Shabrish, I don't know how I was able to like it would have been Greek and Latin to some, at least the clinical crowd, but this is the best possible way that I could make it simple.
Yeah, personally so happy to listen to you after I was just counting the years, almost like 18 years back. I was sitting in your class. So happy to listen to you again, ma'am, on a personal front. And really appreciate the effort you have taken to address such a heterogeneous group of crowd, and the extra effort you have made to tailor it for them. I really appreciate it, ma'am. And also, Anjali will take the honors of being the first PG to speak in this class. Last 3 days, we have been asking PGs to tell something, and nobody has opened their mouth. And I really wish more PGs speak up, ask questions, because this is a very, very unique opportunity you get to directly interact with the various experts in their domains. So again, as usual, I'm requesting any PGs, if you have any questions, please speak up. We will wait for a minute for any questions. If not, we will close the session.
Are there any surgery PGs here? Huh? I think surgery PGs can probably expect something related to my topic in their exam. Other than that, I don't think medical PG, general medicine, the rest of the specialties probably no, but surgery PGs definitely can get something out of it. If there are no questions.
Yeah, I think there are no questions.
Okay, then.
Okay, thank you. Thanks a lot, ma'am.
Okay, thank you.
Good night.
Good night.
All. Bye.